everyone, and welcome to the Science of Childhood Cancer lecture series by the St. Jude Comprehensive Cancer Center. My name is Les Robison. I chair the Department of Epidemiology and Cancer Control here at St. Jude, and we also have the opportunity to serve as the Associate Director for Population Sciences and co-lead, along with my colleague, Dr. Melissa Hudson, the Cancer Control and Survivorship Program within our Comprehensive Cancer Center. This is the fifth week of our 15-week series, and I'm very excited that this is our first lecture that will focus on the topic of cancer survivorship. This is a virtual series that's been an experiment of our Cancer Center during the COVID-19 pandemic. And there's really been great response and engagement to this lecture series. We now have over 2,700 individuals from around the world who have registered for the series and have been participating. So we're very excited and very happy to have people with us today. Before I actually introduce today's speaker, though, I'd like to go through some housekeeping points with you. First of all, this will be a question and answer, but we'll need to do questions actually through the chat function of the WebEx. As you can see, if you please look and identify the all panelist icon on your chat. You can send any questions at any time during the lecture. If you can't use the chat function, you can also email your questions to socc@stjude.org. Now, during the discussion today, Dr. Bhatia has agreed to pause partway through her lecture to take questions that may have come up during the first portion. But then she'll also leave plenty of time at the end of her lecture to, again, answer questions that you might have about the presentation today. And then also, Dr. Bhatia has been very gracious in agreeing to also stay on after the lecture ends at the top of the hour if there are remaining questions that individuals might have, and she's happy to enter into ongoing dialogue and discussions about late effects and bone marrow transplantation. So before we actually get started, I want to have a chance to give you a little bit of background about our speaker today, Dr. Smita Bhatia. Smita did her medical training and also her MD training in pediatrics at the All India Institute of Medical Sciences in New Delhi. After completing her medical training, she came to the United States to the University of Minnesota, where she actually carried out 2 fellowship training programs. First of all, in blood banking, and then she did a fellowship training in pediatric hematology, oncology, and bone marrow transplantation. It was during that second fellowship that she also completed her Master's of Public Health degree in epidemiology. Smita then moved on to her first academic appointment at the City of Hope National Medical Center, where she moved very rapidly through the academic ranks to the point where in a very short period of time, she became professor and chair of the Department of Population Sciences at the City of Hope National Medical Center. She also assumed a number of leadership positions within their cancer center, including Associate Director for Population Sciences, as well as co-leading their Cancer Control and Population Sciences program. In 2015, Dr. Bhatia left City of Hope and moved to the University of Alabama at Birmingham to her current position, where she is currently professor in the Department of Pediatrics and recipient of the Gay and Bo White Endowed Chair in Pediatric Oncology. But she's assumed some really incredible leadership positions at the University of Alabama, and most notably, she went there as the inaugural director of the Institution for Cancer Outcomes and Survivorship. But she also plays a role in a number of areas, such as vice chair of the Outcomes Research for the Department of Pediatrics. She's associate director of the Center for Outcomes and Effectiveness Research. Also, and within the Cancer Center, she is the associate director for outcomes research at UAB. So I think you can see that Dr. Bhatia is incredibly engaged, active, and really taking a leadership. But it's a leadership in the area of pediatric cancer survivorship. And what's really striking about Dr. Bhatia is that she understands the full picture. She's engaged in research that really it spans the entire breadth of the important topics that relate to survivorship following cancer in children and young adults. And it's really that diversity that really makes her such a leader in our field, where she's internationally recognized as one of the people, go-to person in terms of really promoting research as well as mentoring of faculty and juniors trainees in the area of cancer survivorship. If you look at her CV, she is incredibly productive. She has over 300 peer-reviewed publications. She's also the recipient of an NIH Outstanding Investigator Award and also PI of multiple grants. But all the areas of research that she conducts, going anywhere from behavioral research, compliance, to genetics and genetic predictors of late outcomes, to areas of major cardiac and other outcomes within the cancer survivor population. She also is highly engaged in activities of intervention, either behavioral, pharmacologic interventions to try and minimize or ameliorate some of the long-term complications. When she moved to City of Hope National Medical Center, one of the initiatives that she began was the bone marrow transplant survivor study. And this cohort of transplant survivors has been remarkably productive and really given us great insights in terms of what the long-term outcomes of bone marrow transplantation are within the growing number of individuals in the US who are receiving stem cell transplant at this time. And so we're very fortunate today to have Smita with us to give a presentation on some of the research that she's carried out in the area looking at long-term complications following stem cell transplant. Smita, welcome to the virtual seminar series, and we look forward to your presentation.
First of all, Les, thank you so much for this invitation. I am extremely excited and honored to be presenting here. What I want to do, first of all, is to say publicly that all of the work that I have done is due to the mentorship of Dr. Les Robeson. He's omitted to tell you that as a fellow, he took me by my hand and essentially allowed me to grow. And at each step, that has been the case. So having said that, this particular blood or marrow BMT transplant survivorship study that I'm going to be focusing my work on today, a large part of it is based out of discussions initially that I had with Les, and then of course it took a life of its own. So thank you, Les. Why do we want to do this particular talk on BMT? What I want to do over the course of the next 40 to 45 minutes is to walk you through just an overview of what BMT is about, the burden of morbidity in BMT survivors, the impact of chronic graft versus host disease, the bane of existence of allogeneic BMT on the outcomes. And then at this point, I think I will pause and see if there are any questions. And after having dealt with that, move on to late mortality, cardiovascular disease, subsequent neoplasm, cognitive impairment, and then talk about a little bit about life expectancy in patients who've undergone BMT. So let's start at the beginning, an overview. So just to give you a brief history, in 1968, the world's first successful human bone marrow transplant was performed at the University of Minnesota by Dr. Robert Good. The transplant was performed in an infant with an immune deficiency syndrome using an HLA-matched sibling donor. In 2020, today, BMT is used with absolute curative intent and for a variety of life-threatening illnesses. How many transplants are performed in the US? And here we go. About 14,000 plus autologous transplants, about 10,000 allogeneic BMTs, for a total of about 24,000 BMT recipients per year. What types of allogeneic BMTs are performed? Leading that pack is the unrelated donor transplants. Sibling transplants follow. These are the HLA-matched sibling donor transplants. increasing rapidly are the other relative transplants, what are called the mismatched related donor transplants, and then cord blood transplants, which have leveled off and are not so much in vogue these days since the other relative transplants have taken on. What are the indications for BMT in the US? And this was, these are slides from CIBMTR. And what we see for autologous transplants, it's primarily myeloma and non-Hodgkin lymphoma, some amount of Hodgkin lymphoma, and some other solid tumors, especially in children. For allogeneic BMT, it's acute myeloid and lymphoblastic leukemia and MDS, non-malignant diseases such as inborn errors of metabolism and immune deficiency, and then aplastic anemia and very small numbers of chronic myeloid leukemia as well as CLL. What's happened is there have been several significant trends in allogeneic BMT as well as autologous in the US. And what I'm showing you here, which will color the talk quite a bit throughout, is the fact that there has been an increase in the number of patients who are older who undergo transplant from 2000 up to 2018. The same is true and even more so for autologous BMT, where the number of people is more amongst those who are older as compared to those who are younger at the time of autologous BMT. So then what does this mean in terms of the prevalence of BMT survivors? This was a study which was published in 2013 and obviously needs to be revised again, but this is the most recent numbers that we have. From 2009 to 2000 projection of 2030, there is an increasing or will be an increasing number of BMT survivors from 109,000 to about 250,000 currently to over 500,000 by 2030. How does this translate into the type of transplant survivors? Autologous BMT, the largest number, followed by allogeneic related and allogeneic unrelated BMT transplant recipients. And then BMT survivors by age at BMT. 18 to 59-year-olds are going to be the most prevalent of all, followed by the elderly, and then of course the younger transplant survivors. So now that I have laid some kind of a groundwork on an overview of what BMT is about, let's talk about the burden of morbidity in BMT survivors. Now, across the lifespan of an individual from the time of BMT, there are, of course, early complications, and most people who do transplants are aware of those. And those are the ones that one has to cross over by day 100 in order to think positively about moving forward to the survivorship phase. Then comes what are called delayed events, up to 2 years, late events, up to 10 years, and then very late events. And what are these delayed events? These are pulmonary complications, chronic graft versus host disease, infections, ocular complications, venous thromboembolism, metabolic disorders, and cognitive impairment. Late events include endocrine complications, osteonecrosis, chronic kidney disease, and then, of course, the metabolic disorders, the infections, the cognitive impairment, and sexual dysfunction. And then the very late events include cardiovascular disease, subsequent neoplasms, liver cirrhosis, and then sequelae of chronic graft versus host disease in the form of esophageal atresia and vaginal stenosis. What's important to note is many studies have shown that there is improving physical and psychological performance as the patients move away from the transplantation, and then also societal reintegration. Why do we want to follow bone marrow transplant survivors or blood or marrow transplant survivors for life? This is why. A patient is diagnosed with a primary cancer, and often, unfortunately, the patients relapse. And I'm talking about across the age trajectory, up into the oldest of old adults who undergo treatment for cancer. And because of the patients have refractory disease or are at increased risk of relapse or have actually relapsed, they are taken in for BMT. Post-BMT, the allogeneic transplant population, about 30 to 40% of them develop chronic graft versus host disease. They may have post-BMT relapses of their primary cancer. So because of this, there is extensive amount of pre-BMT therapeutic exposures. there's high intensity BMT-related exposures, and then of course, depending on the post-BMT complications, there are post-BMT therapeutic exposures, and all of these increase the risk of post-BMT late effects. And this is the topic of our conversation. So let's see for a moment whether the prevalence of adverse health status is higher amongst transplant recipients compared to those who are conventionally treated for cancer. If you look at chronic health conditions, and here I will walk you through what these bars stand for. The white bars are siblings drawn from the CCSS population, unaffected siblings. The light gray bars are the CCSS conventionally treated population, and the black bars are the BMT survivors from the BMT survivor study, which I will introduce you to later. But what's important to note is when you look at grades 1 through 4 chronic health conditions, the BMT survivors have the highest prevalence of these outcomes. The same is true for grades 3 or 4 conditions, and the same is true for people who have 2 or more conditions. And this is true also for adverse health status, poor general health, functional impairment, and activity limitation. This study was led by Saro Armenian. He's one of the collaborating sites and had done a wonderful job on this paper. So here we see that the relative risk of grades 3 to 5 chronic health conditions amongst BMT survivors is 3.9-fold as compared to conventionally treated patients. For general health, 2.8-fold higher risk, functional impairment, 3.5-fold higher risk, and activity limitation, 5.8-fold higher risk. Let's talk about the burden of morbidity in BMT survivors and what the gaps in knowledge are currently. We really don't know the magnitude of risk of morbidity, especially with the changing practice. The etiology and pathogenesis of these complications still remains to be studied. And then identifying those that are at the highest risk of these complications so we can really do a targeted, informed intervention in those patients remains to be studied. So this was the reason for establishing the BMT survivor study that Les talked about, established in 2000, but then expanded as of about a year and a half ago. Who are eligible? BMT performed between 1974 and 2014. Survival of 2 or more years after BMT, irrespective of vital status at the time of study. And then BMT performed at one of the 3 participating sites, City of Hope, University of Minnesota, and then University of Alabama at Birmingham. This has yielded us about 10,000 BMT survivors who are eligible to participate in the BMT survivor study. We also recruited a non-cancer comparison group, which is the siblings of the BMT survivors. And this funding initially came from an R01 through the NCI. Leukemia Lymphoma Society held our hands in the middle, and then recently the NCI came back again with a U01 funding mechanism. Now, what are the methods? We administer a BMT survivor study survey, which includes the sociodemographics as well as chronic health conditions, graft versus host disease, fertility status, health status, new neoplasms, very similar to the CCSS survey, but modified to accommodate the needs of the BMT population. We ask for a saliva sample for germline DNA. We use the medical records for treatment characteristics as well as source validation of the chronic health conditions. And then we obtain the vital status information from a mix of medical records as well as the National Death Index. We have graded the chronic health conditions reported by the patients using the CTCAE grading criteria, which are shown here. And the grades 3 to 5, the severe, life-threatening, disabling, or adverse event-related deaths include subsequent neoplasms, cardiovascular disease, respiratory problems, GU problems, musculoskeletal problems, endocrine dysfunction, and then GI problems listed here. And this yielded the following study, which showed in 2010, when we used the previous version of the BMT survivor study, that nearly 60% of the patients had any grade 1 to 5 condition at 10 years out. And in terms of grades 3 to 5, the cumulative incidence was 35%. What are those conditions? They include subsequent neoplasms, cataracts, osteonecrosis, venous thromboembolism, and diabetes. What I want to do now is to focus on the impact of chronic graft versus host disease on BMT outcomes. And here I'm going to show you cumulative incidence of grades 3 to 5 health conditions by chronic graft versus host disease status, where we show that the risk of developing these complications is higher amongst those who have had chronic graft versus host disease as compared to those who did not. And what are those conditions? They are primarily in the form of osteonecrosis, chronic kidney disease, venous thromboembolism, frailty, and then chronic severe pain. So let's go down the list of these complications and give you a better sense of what is the magnitude of these problems. Late osteonecrosis is truly a disabling condition in allogeneic BMT recipients as shown here. 15% risk at 10 years for unrelated donor BMT recipients, 6% for allogeneic related BMT recipients, and 4% at 10 years for autologous BMT recipients. Who are the people who are at risk? It's individuals who've received calcineurin inhibitors for their chronic graft versus host disease, and then independently just the fact that they have had chronic graft versus host disease. Let's talk about chronic kidney disease. Exposure to calcineurin inhibitors and at an older age at BMT is associated with a much higher risk compared to those who never received any calcineurin inhibitors and were younger at the time of transplant. Venous thromboembolism is a fairly disabling complication in our population of BMT patients. And here we have an incidence of 6% at 10 years amongst those who received an autologous transplant. The survivors versus siblings, 2.6-fold increased risk. When you look at the late mortality with and without venous thromboembolism, overall survival, we see that there is a difference between those who had venous thromboembolism, inferior survival, as compared to those who did not have venous thromboembolism. There's no difference in relapse-related mortality, and most of the difference in outcome is related to those who have suffered non-relapse mortality, so higher risk of non-relapse related mortality amongst patients with venous thromboembolism as compared to those without venous thromboembolism. Let's stop for a moment and discuss frailty. What is frailty? Frailty is a clinically recognizable state of increased vulnerability. It results from aging-associated decline in reserve and function, and it happens across multiple physiologic systems such that the ability to cope with stressors is compromised. We measured the risk of frailty in our BMT survivors compared to siblings, and these BMT survivors were between 45 and 60 years of age, and the risk is only 8.4-fold higher amongst BMT survivors compared to siblings. And when we look at the risk factors for frailty, we find that compared to autologous BMT recipients, allogeneic transplant recipients without chronic graft versus host disease are not at an increased risk. Those who have resolved chronic graft versus host disease are at a modestly increased risk, whereas those who have active chronic graft versus host disease have a 15-fold increased odds of having frailty as compared to those who have undergone an autologous BMT. In addition, those who have chronic health conditions, serious or life-threatening, are at a 2-fold higher risk of reporting frailty. And then what we said was, okay, let's take a look at subsequent mortality amongst those who are frail versus those who are not frail. And what we find is that those who had reported frailty, and we followed them for about 10 years after or beyond, the people who had reported frailty were at a 39, the risk of mortality, all-cause mortality was 39%, whereas it was about 15% for those who had no frailty. And when you adjust for all other causes of all-cause mortality, individuals who were frail were 2.8-fold more likely to die of any cause as compared to those who were not frail. So then there are, in the non-oncology geriatric literature, some studies that have reported that frailty is a dynamic condition, that there are some individuals who are frail and improve, there are some individuals who remain stable at the same state, and there are some who worsen. And so what we did was we took and administered the frailty phenotype, assessed the frailty phenotype at a particular time called time 1, waited for another 13 years, and then administered another questionnaire to assess frailty at time point 2. And what we find is that we're looking for change in frailty phenotype, and we're looking for predictors of worsening phenotype. And this is the story here. This is how it changes. About 20% of our patients worsened in terms of frailty, 10% improved, and about 70% remained stable. So what were the predictors of worsening of frailty status? Females were more likely to have worsening of frailty status, but an equally important and interesting observation was the fact that individuals who had received vincristine prior to transplant were 6-fold more likely to have worsening of their frailty status as compared to those who did not. So now let's look at, turn our attention to pain, chronic severe pain, long-term out in BMT survivors. And again, we're comparing survivors with siblings. 39% of our survivors report chronic severe pain. 21% of the siblings do. And there's a 2.5-fold higher odds of our survivors reporting chronic severe pain as compared to the siblings. What interested us at this point was the pain well managed? What were they receiving in terms of prescription pain medications? So our survivors were more likely to receive prescription pain medications as compared to siblings, and were more likely to receive opioids as compared to siblings. But what was most important to note was that even after adjusting for chronic severe pain, our survivors were 1.7-fold more likely to receive prescription pain meds and 2.5-fold more likely to receive opioids as compared to the siblings. An equally important question is, how is this chronic severe pain associated with activities of daily living? When we look at this, we find that chronic severe pain in allogeneic transplant recipients is associated with a 2.7-fold higher odds of impairments in activities of daily living and 3-fold higher risk in amongst the autologous BMT recipients. But most importantly is the frailty question, and this is pretty sobering, where we find that our allogeneic BMT recipients 8-fold higher risk of reporting frailty if they have chronic or severe pain, and 7.5-fold for the autologous BMT recipients. And this would be a good time for me to stop and see if there are any questions.
Thank you, Smita. Yes, a number of questions have come in. Serve sort of as the moderator to read some of them off. And first of all, we'll start with quite a number of the people chatted in regarding the data that you showed relative to frailty and vincristine. Yeah. And the questions that really are focusing around, how much is known, or is there information that whether or not it's true peripheral neuropathy, or what is the mechanism that you see in terms of that vincristine, and how far have you been able to assess the real underlying pathophysiology?
Absolutely. So yes, we have to say that this is qualified as answer by saying that this is in the context of a self-report survey. So when we look to see that the vincristine-associated frailty what were the criteria amongst those patients who reported vincristine-related frailty? It was primarily muscle weakness. And so our assumption is that these patients had some amount of neuropathy, which worsened their muscle weakness and increased their risk of frailty over time. So that's our thought process here.
Great. Other questions regarding some of the information relating to frailty. A question about how you actually measured frailty relative to the Freed Frailty Index and so forth. If you can speak to that just very briefly.
Right, and that's a great question. So there are 5 criteria, and I didn't include them here, but there are 5 criteria that are used by Freed, and there were 5 comparable criteria that we used by self-report. What we had to do was become creative in terms of saying, are those criteria which include grip strength amongst in the Freed criteria, or the gait speed in the Freed criteria, how would we translate that into self-report? And what we did was we used questions within our BMT Survivor Study survey to address similar domains or constructs for grip strength and for gait speed. And then we came back and because we wanted to convince certain reviewers down the road for a subsequent grant, we called back patients. We called back about 30 patients and asked them to complete the survey. And then we assessed their frailty using the strict Freed criteria and found a very high correlation between the two.
Excellent. That was actually another question that just came in is about have you assessed self-report versus physical exam. So that's actually excellent. But that also raised the question about, do you see actually differences in terms of the quality of reporting between men and women in terms of the frailty phenotype?
Did not look at that. I just wanted to say that, there has been traditionally report of higher self-reported frailty amongst females as compared to males, but in the BMT Survivor Study, we did not find gender differences in frailty.
Great. 2 more very quick questions, and we'll let you move on. One of the participants asked about the pain data. Do you have information on the type of pain the bone marrow transplant patients are reporting?
Mm-hmm. And there are different sites that these patients are reporting. Most of them had pain related to their chronic graft versus host disease. So it was either musculoskeletal pain related to their articular joints, which were affected, or it was just generalized body pains, but severe enough to interfere with daily functioning.
Okay, and the last question, even though we have many here, that we'll maybe be able to get to some of the others at the end of your talk to address them. But one also, can you talk a little bit about the potential role of TBI in osteonecrosis and the risk of osteonecrosis? And have you seen changes in terms of that risk with the integration of more busulfan in terms of the preparative regimens?
Right. And so when we looked at this data, and this is slightly dated right now, the osteonecrosis data, we had not found an association with TBI. What we do want to do now with the decreasing prevalence of TBI, use of TBI, is to look at this information again. And I will show you down in the last few slides at the end of the lecture how the strategies of management have changed, and this will be a good opportunity for us to examine the osteonecrosis question again in light of TBI.
Okay, great. Well, thank you. And there's quite a number of questions we didn't get to, but we'll come back to some of those at the end of your talk. So we'll let you move on now.
Thank you. All right. So now we're going to briefly touch upon late mortality, knowing that I will be talking about life expectancy and late mortality right at the end again, but this is just to set the stage for cardiovascular disease and subsequent neoplasms, so bear with me. When we looked at late mortality, and this is now, 15 years old, so I promise you more updated data towards the end of the talk, but things haven't changed much. Here's what it is. When you look at the survival rates for the US general population amongst males, and compare it with our BMT survivors, the male survivors, we find that there's a difference. And again, it's the same for the US females and our female BMT survivors, a growing separation of the two curves. There's a 13-fold higher risk of our BMT survivors in terms of all-cause mortality as compared to the general population. And the overall survival at 10 years was close to 70%. And this is for autologous BMT recipients. The same is true for allogeneic BMT recipients. You have to know that these are 2-year survivors when they're coming into this particular cohort. 80.4% 10-year survival and a 10-fold higher risk of late mortality. But when you look at the cause-specific late mortality after BMT, and I'm showing you the data from autologous BMT recipients, we find that while the relapse-related mortality sort of plateaus out and is not so high, that for non-relapse-related mortality continues to increase. And what are the causes of non-relapse-related deaths? These are subsequent neoplasms and cardiopulmonary disease. When we look at allogeneic BMT recipients, it's the same story, plateauing out of the relapse-related mortality, but increasing numbers of non-relapse-related mortality, where the causes of death are again subsequent neoplasms, cardiopulmonary disease, and late infections. Going to talk about cardiovascular disease now, just since this is one of the 2 leading causes of non-relapse-related mortality. And amongst them, I'm going to focus briefly on anthracycline-related congestive heart failure. This was a study, again, led by Marrow, Armenian, when I was at City of Hope. And what we showed was that when amongst those BMT recipients who had received high-dose anthracyclines prior to BMT, the risk of developing heart failure was 10-fold. Amongst those who had received high-dose anthracyclines and also had diabetes, the risk was 27-fold higher. And then the risk of developing anthracycline-related congestive heart failure was 35-fold higher if hypertension was in the mix. The comparison group was no anthracyclines. So these particular diabetes and hypertension, which are conventionally called the cardiovascular risk factors, are a problem in our BMT survivors. How much of a problem is shown here. Here we are comparing our population with the NHANES data. 35% of the general population has hypertension. About the same of our autologous BMT survivors have hypertension. However, 43% of our allogeneic BMT recipients have hypertension. Here's the data for diabetes, for dyslipidemia, and for people who have 2 or more cardiovascular risk factors. What is the absolute cumulative incidence at 10 years for our BMT survivors? Dyslipidemia, 47%, hypertension, 38%, diabetes, 18%. And what are the risk factors of these particular cardiovascular risk factors amongst our BMT survivors? For all cardiovascular risk factors, the older you get, the higher the prevalence of or the risk of developing cardiovascular risk factors, and also obesity is a risk factor. Grade 2 to 4 acute graft versus host disease is also associated with all cardiovascular risk factors. And total body irradiation is associated with diabetes and dyslipidemia. So then Marrow asked this question and said, if we were to look at the cumulative incidence of cardiomyopathy with only cardiovascular risk factors, what would be the story? So look at the first panel. And what we find is that those who have 2 or more cardiovascular risk factors have a much higher risk of developing cardiomyopathy as compared to those who have no cardiovascular risk factors. Looking at panel 2, you add cardiotoxic drugs in the mix, you find that the risk is so much higher as compared to those who have no cardiotoxic drugs and less than 2 cardiovascular risk factors. And the same is true for autologous BMT recipients as it is for allogeneic BMT recipients. So then the question becomes, can we predict the risk of anthracycline-related cardiomyopathy? And this is a study that we've recently analyzed. And here we're looking at BMT survivors. And we find that if we construct a clinical model which only has age, sex, anthracycline exposures, as well as chest radiation in the model and cardiovascular risk factors. The AUC, or the area under the receiver operating curve, characteristics curve, is 0.64, but you add genetics to the mix and the risk increases to, the AUC increases to 0.72. And these are the 10 SNPs on 8 previously published genes that were incorporated into this model. Now let's briefly talk about subsequent neoplasms. When we're talking about subsequent neoplasms, and we're looking at two kinds of subsequent neoplasms, these are solid tumors and therapy-related leukemia. So let's talk about solid tumors first. We looked at this amongst about 7,700 patients where 570 had developed solid tumors. The cumulative incidence was 15% at 25 years. But as you can see, the risk continued to increase from BMT. Here's therapy-related leukemia. 2,293 patients, 112 developed therapy-related leukemia. Another story is that therapy-related leukemia develops only in autologous BMT recipients, largely, very, very, very rarely in allogeneic. So these are all autologous BMT recipients where the risk is about 6.5% at 15 years. Risk continues to climb till about 10 to 15 years, but then plateaus off. Occasional patients are seen at later time points. What are the types of subsequent malignancies? We discussed the therapy-related leukemias, but then there are the skin cancers. A large proportion of these people have basal cell carcinoma as well as squamous cell carcinoma. Breast cancer accounts for a small fraction, and then even smaller fractions are the other solid tumors shown here. I'm going to talk briefly about breast cancer and then talk in detail about therapy-related leukemia. So our interest stemmed from the fact that we wanted to find out if TBI would constitute as an exposure to identify those at risk for breast cancer, and then to determine whether we would recommend screening, similar to how we do for our patients with Hodgkin lymphoma or others who receive chest radiation. So here's our findings. If you look at this particular graph, it's the x-axis shows attained age, and we find that the risk of breast cancer is lower amongst those who did not receive TBI as compared to those who did receive TBI. This is true for allogeneic BMT recipients as well as autologous BMT recipients who also, in addition, have an increased risk upon exposure to alkylating agents. Now, what we also found was that TBI at age 30 was associated with an increased risk of breast cancer, as shown here. For the entire cohort, a modest increase in risk of breast cancer as measured by standardized incidence ratio. If they received TBI, the risk is increased 50%. If they received TBI for allogeneic BMT at age less than 30, 4.4-fold increased risk, but not so if they received TBI at age greater than 30. The same is seen in autologous BMT recipients. So let's now talk about MDS and AML. Therapy-related leukemia, like I said, is associated with tremendous activity early on after BMT and then much lower activity. High fatality rates are characteristic of therapy-related leukemia, such that the salvage rate is very poor unless allogeneic transplants are used in this population, in which case about 20 to 30% have some amount of durable remission. We established a prospective longitudinal study in patients undergoing autologous BMT for lymphoma, where we collected bone marrow and blood prior to transplantation. These patients underwent an autologous peripheral stem cell transplant, and then at day 100, 6 months, 1 year, and then annually with occasional half-yearly marks, we collected blood and marrow again right up to 10 years. The goal was to study pathogenesis and prediction. And this was our hypothesis, or working hypothesis, that genotoxic insult in the face of genetic susceptibility would result in acquisition of mutations, which in the face of proliferative stress and genomic instability would result in clonal hematopoiesis, result in cytogenetic abnormalities, and then clinical or morphological MDS. And so let's talk about genetic susceptibility briefly. And here we're looking at gene expression changes in CD34 positive cells in patients undergoing autologous BMT for Hodgkin lymphoma. So this was our study design, if you remember, and we collected peripheral blood stem cell products at the time of transplant, and we followed the patients up to the development of therapy-related leukemia. Those who developed leukemia were called cases. Those who didn't were controls. Once we'd identified the cases and controls, we went back to take out their peripheral blood stem cells, and we then looked to see the differential gene expression in the CD34 positive cells from the peripheral blood stem cell product. And this is the heat map, and what we find is that there are changes in gene expression that are associated with the development of therapy-related leukemia, and we can identify these changes in the CD34 positive cells from the peripheral blood stem cell product. So I don't think you can see, and I apologize for that, but these are the cases, and these are all the controls. These are the genes, and you can see that it clearly differentiates in terms of what is downregulated, what is upregulated, and down and upregulated. What this helped us do was create an optimal 38 gene peripheral blood stem cell gene signature, which accurately distinguished patients prior to their transplant who were at risk of subsequently developing therapy-related leukemia. The specificity was 95% and the sensitivity was 88%. Let's talk about genomic instability briefly. We used telomere length as a marker of genomic instability, and we actually measured telomere length in the white blood cell subpopulation. So here's the myeloid telomere length, which actually gave us the answer to the story. What we see here on the x-axis is the days after transplant, and where we stopped was we censored the patients at least 3 months prior to development of therapy-related leukemia. And what we see is that the telomere length remains pretty stable for the controls, but there's significant attrition in telomere length for the cases, suggesting more genomic instability even months prior to the development of therapy-related leukemia. Proliferative stress, how did we measure that? We measured that using primitive and committed progenitor frequencies in the bone marrow. And here we look at primitive progenitors. This is the number of primitive progenitors, and we find that on day 100 and beyond, there's a profound and persistent reduction in the primitive progenitors, and it really doesn't come back to the pre-transplant level. Committed progenitors, however, have a different story. We find that there is an exuberant proliferation of the committed progenitors for the entire cohort, but not so much for those who eventually develop cases. So there's a transient reduction in the committed progenitors, but there's a reduced frequency in patients who developed TMDS. And this can be found in another way. When we looked at serial platelet counts prior to development of therapy-related leukemia, so here we're looking at months from BMT. The patient is developing therapy-related leukemia months after, and here is the serial platelet count for the controls, and here it is for the cases, showing that there is a separation between the two several months before they develop therapy-related leukemia. And this is true for serial hemoglobin levels as well as serial white blood cell count. And recently, not shown here, is what we've done is we've developed a risk prediction model using these peripheral blood parameters in order to identify individuals on day 100 who are at risk for subsequently developing therapy-related leukemia. Let's talk about clonal hematopoiesis. So what is clonal hematopoiesis? It's really come in to its own life here now recently. CHIP, as it's known, is the presence of a somatic mutation in a leukemia-associated driver gene at a variant allele frequency of 2% or more. There has to be an absence of peripheral blood cytopenia, And there has to be exclusion of MDS and of all other hematopoietic neoplasms as the underlying cause of this particular somatic mutation in order for it to be called CHIP. This was a seminal publication in 2014 by Ben Ebert's group in the New England Journal of Medicine, where they looked at the prevalence of these mutations in people by age and saw that those who aged had a significant increase in the prevalence of somatic mutations. And these mutations were primarily in genes such as DNMT3A, TET2, and ASXL1. So, and they also showed in that particular paper that individuals with CHIP have a 10-fold higher risk of subsequently developing a hematological malignancy. So what we hypothesized was that CHIP, prior to transplant for non-Hodgkin lymphoma, would be associated with an increased risk of therapy-related leukemia and also of inferior survival after transplant. We looked at 401 lymphoma patients treated with autologous transplant. This was in collaboration with Ben Ebert and Chris Gibson out of Boston. And again, we're looking at the prevalence of individuals with somatic mutations. And what we have to see is those who are 20 to 29 years of age, none of them have CHIP. Low frequency in 30 to 39 years of age. But then the activity starts picking up and the prevalence increases as you age. And what were the mutations? The most common were the ones which are aging-associated and leukemia-associated, PPM1D, DNMT3A, TET2, TP53, and ASXL1. And then the meat of the study was, is it associated with therapy-related leukemia? And yes, indeed it was. Those who had CHIP were at a much higher risk of developing therapy-related leukemia as compared to those who didn't. We have to remember we measured this CHIP in the peripheral blood stem cell product. And this is overall survival, those who had no CHIP versus those who had CHIP. And this is event-free survival, those without CHIP and those with CHIP. Okay, so I am moving now to cognitive impairment. And why am I moving to cognitive impairment? Because as I had stated before, BMT is used with curative intent for a variety of life-threatening illnesses. And while our focus is on curing individuals, for the patient, it is also important to be able to integrate back in society, to return to work, to reclaim their place in society. And that is a success that they measure their lives by. And for that, we need to study whether these patients have any cognitive issues as a result of BMT. So we conducted another longitudinal study. Here we measured neuropsychological functioning in patients prior to transplant, and then at 6 months, 1 year, 2 years, and 3 years. We did the same thing for healthy controls, a baseline and then commensurate time points up to 3 years. And we used measured 10 domains, 14 tests, and we measured IQ at baseline to serve as cognitive reserve, and we measured fatigue self-reported at all the time points longitudinally. The battery took about 2 to 2.5 hours to complete. And this is what we show. What we find is, and I'll orient you to the slide, we're looking at executive functioning here. The higher the score here, the better the cognitive performance. The red line is the healthy controls. The blue line is the autologous transplant recipients. The gray line is myeloablative transplant recipients. And the yellow line is the reduced intensity allotransplant recipients. So what we show out here is while the autologous transplant recipients are performing similar to the to the healthy controls, it's the allogeneic transplant recipients who are impaired, and it appears as if the reduced intensity transplant recipients take a bigger hit down the road. This is verbal speed, similar story. Here the myeloablative transplant recipients take the biggest hit. Working memory, myeloablative transplant recipients. Auditory memory, again, the myeloablative transplant recipients. And when we look at this in the form of a global deficit score, and here we're looking at the odds ratios with their surrounding confidence intervals with a P for trend for across the time points, we find that the autologous transplant recipients are not at an increased risk. We look at myeloablative transplant recipients, the risk increases with time. And then we look at overall transplant, the reduced intensity allogeneic transplant recipients, and we find that it is only increasing towards the end with a positive, significant P for trend. So the question that I'd asked before was, are these people able to return to work, and does cognitive impairment have an impact on their ability to return to work? Overall, we found that those people who participated at the 3-year time point, only 30% of them had not returned to work. So 70% were able to return to work. Amongst autologous transplant recipients, only 20% were not able to return to work. Reduced intensity allogeneic transplant recipients, 31% were not able to return to work, but myeloablative allogeneic transplant recipients, 46% were not able to return to work. Global cognitive deficit was associated with a 10-fold increased odds of not returning to work. And so this was an important finding and has led to some intervention studies that we are conducting now. Okay, then we said, what is the cause of this inter-individual variability in terms of risk? We give chemotherapy and radiation and steroids to our transplant recipients. It causes oxidative stress. There's telomere shortening. There's DNA damage. There's neurodegeneration, and it leads to cognitive impairment. And this pathway can be moderated or mediated by blood-brain barrier transporter genes, which have been associated with cognitive impairment in Alzheimer's disease, telomere homeostasis disease genes, which have been associated with Alzheimer's also, DNA repair genes, again, Alzheimer's, ataxia-telangiectasia, and xeroderma pigmentosum, all of which are associated with cognitive impairment. Neurotransmission genes, which have been shown in breast cancer to be associated with chemo-induced cognitive impairment, and then neural repair genes found in Alzheimer's disease. So we identified or curated 985 SNPs in 68 candidate genes and conducted an association study and found associations in our population with DNA repair genes, blood-brain barrier transporter genes, and telomere homeostasis genes. And then we said, let's take a look to see if it improves our ability to classify patients in terms of their risk of cognitive impairment. And here is the clinical model, the genetic model, and the combined model. This was discovery and significant differences, and then replication also replicated in terms of the final model, which included both the clinical and the genetic pieces. Right at the end, we want to talk about life expectancy. Again, the issue of curative intent. Here what we find, and this is really unpublished data right now, is deaths per 1,000 person years in allogeneic transplant recipients, so about 4,000 individuals. And what we show is attained age here from 0 to 80, and the dashed lines are the expected mortality rate, and this black solid line is the mortality rate amongst our population of BMT survivors. And this is something that Les has always talked about, that our survivors have a higher risk of adverse events or deaths, and it is shifted to the left. And this is what we are finding. The separation is here. The separation is bigger here. The inflection is here for our transplant recipients, and here for the expected general population. So the mortality rate increases at a faster pace in our BMT survivors. So what does this mean in terms of life expectancy? In terms of today's life expectancy, there's an absolute reduction in life expectancy. For a 10-year-old who's undergone BMT, 21 years of his life are shaved off. For a 70-year-old, 1 year of their lives are shaved off. Relative reduction, 31% of the life expectancy is reduced for a 10-year-old, 8% for the 70-year-old. Okay, I'm going to very quickly go through changes in our transplant practice because I want to promise to stop at a positive note. these are the three eras we created. And what we found in our group was that there's an increase in number of unrelated donor transplants, a slight increase in the number of Hispanics and Asians undergoing transplant, a significant increase in number of the older populations, which I'd alluded to earlier, undergoing transplant, reduction in the number of people receiving TBI or myeloablative BMT, an increase in number of cord blood stem cells, but definitely an increase in number of PBSCs or peripheral blood stem cells. And when we look at the decline in late all-cause mortality after allogeneic BMT, we find that there indeed is a decline when you compare to those who were transplanted before 1990. Not so in the relapse-related mortality across these two time periods at least, but definitely so in the non-relapse related mortality. And I have to tell you that I truncated this at 10 years post. So it's not because of the fact that the previous generations have had a longer time to live and we haven't, this particular generation hasn't had long enough time to develop their relapse related mortality. We have to continue to treat our bone marrow transplant patients. They develop adverse events, and these are all the factors that cause the increase in adverse events. Need to identify high-risk groups to undergo all of these interventions in order to take care of these adverse events. So are we there yet? I don't think so, but we're solidly on the right path. This is my funding. These are the people who really contributed to all the work, and these are the survivors who we need to appreciate in terms of, you know, making life better for the next generation. And I want to thank you here.
Thank you very much. We're now at the top of the hour, Smita, and so we want to really thank you for a great talk. And this will close the official part of the event right now. But again, we invite people to stay on if they'd like to ask some additional questions, and certainly questions have been coming in during your talk that we'll be able to have you respond to in just a little bit. So I'd like to thank everyone for coming and joining us. I'd also like to encourage you to look at the website and to mark your calendars for upcoming events. We have several others that are going to focus on cancer survivorship, including a talk by Dr. Kevin Kroll from here at St. Jude, as well as Dr. Eric Chow from the Fred Hutchinson Cancer Research Center. So again, thank everyone for participating and listening to Dr. Bhatia's talk, and feel free to stay on as we continue our discussions. Thank you, everyone. Okay, Smita, if you have a little bit of time here, let's go through. There's quite a number of questions that came in, and I'll try to sort of summarize and put some of them together, because I think there were a number that have common themes that were brought up by people going through here. One of them relates to the age, and you gave several examples how age at transplant makes a difference in terms of the risk for specific outcomes, such as secondary breast cancers and so forth. But can you give just a sort of your general impression and so on, how the real marked differences between those that are transplanted in the pediatric age group versus the adult age group, what the real distinct differences in terms of risks that you're seeing?
Right. So it all depends on the particular complication list. So what we are finding is that individuals who are, where we're looking at, say, stroke or coronary artery disease, it is very clear that those who are transplanted at an older age are at a greater risk of developing these complications. And in part of this is because of the fact that the cardiovascular risk factors accumulate as you age, and they play a role in the patients who develop, say, stroke or cardiovascular disease, or even diseases such as deep vein thrombosis or pulmonary embolism. On the other hand, radiation-associated factors which increase the risk of certain complications, for example, breast cancer. It is the interaction almost between the young age and exposure to a particular tissue, which increases the risk of that complication. So breast cancer is an example. And then cognitive impairment, which I didn't show you out here, is that we had found an interaction between young age, and exposure to TBI, which increased the risk of cognitive impairment. So it all depends upon the particular outcome and the exposure that we're looking at.
Great. Also, along that line, there were questions that came up from a number of the participants that really did relate back to TBI. And specifically, if you could talk a little bit more, they had questions relating to, do we really see differences, and how much of a difference do you see relative to the dose and the actual delivery of TBI relative to some of these late outcomes?
Right, and those are fantastic questions. So when we were looking at the breast cancer story, what we saw very rapidly was that while there has been a tendency towards using non-myeloablative doses of TBI, the 200 and 400 centigrade, there's not enough of a number in order to help us examine that particular question. What we do know, most of the people get somewhere around 1200 to 1320 centigrade of radiation in the form of TBI. What has happened in the more recent eras is that we started using fractionated TBI. We used to use single dose TBI before. And a classic example is cataract. Cataract developed almost like in 90% of the individuals amongst those who had received a single dose of TBI. But when fractionated TBI came into being, what happened was that the curve shifted to the right, and there was a slight lowering in the incidence of cataracts. And this is the same analogous story that I used in my cognitive impairment story, where I showed that those who had reduced intensity transplants had developed their outcomes slightly later, and they were also at a slightly lower risk of developing that particular outcome. So that's what we're doing. We're shifting the curve to the right, and we're reducing the risk somewhat by fractionating the dose of TBI.
Great. Well, along those lines, in terms of talking about some of the other related issues, a number of the participants raised questions about GVHD and steroids, and how much of some of the, such as with cataracts, for instance, and so on, how much do you think might be driven from the actual use of steroids for the treatment of chronic graft versus host disease?
Right. And so cataracts is a very classic story where, most of the patients receive TBI, quite a few develop chronic graft versus host disease. And when they were developed chronic graft versus host disease, steroids is always the go-to medicine in addition to the other calcineurin inhibitors and such. So in order to tease all of these things apart, it becomes hugely impossible. We do say, yes, we can look at Bucy or busulfan cyclophosphamide as a conditioning agent, but we have to remember that a very small proportion of patients receive Bucy as their conditioning. So it does become a difficult question to tease apart. But in order for practical purposes, if a patient comes in and has received any or all of these agents, I would say that we need to look for cataracts.
A couple of questions also came in around some of the data that you presented on risk of secondary breast cancer, and I'll throw a couple of them out. One queried the issue of, did you see in terms of anthracycline association, which we now see in our non-transplant population, if that was a contributing factor in terms of the pre-transplant therapies. And the second one actually related to the issue about infertility or primary ovarian insufficiency, and how that might actually contribute to the risk of the secondary breast cancers in this population.
Right. And so both are very good questions. For anthracyclines, we found a small signal, but it was not statistically significant. Alkylators, on the other hand, were significantly associated. So that was the first question. The second question, we looked at all the factors that are conventionally associated with increased risk of breast cancer. For example, age at menarche, age at menopause, exposure to hormone replacement therapy, and also lactation or pregnancies. And we did not find an association in the face of TBI.
A question that actually comes up, and that I think is a great way to start to think about some of this too, is can you address something that relates to what possible interventional studies might be considered for when you're looking at this group of individuals with higher risk of treatment-related AML or MDS?
Mm-hmm. So in terms of, so there's different ways of intervening. One of them is if you were to identify, say, at the time of transplant, if you're taking a patient up for an autologous transplant, you identify that they are at a very high risk of going on to develop therapy-related leukemia, we would consider a reduced intensity allogeneic transplant rather than offering them an autologous transplant. That is one thing. If we were to identify patients who subsequently develop, have undergone an autologous transplant and are identified to have, low risk or, almost like sputtering kind of a therapy-related leukemia scenario where some cytopenias, no chromosomal abnormalities, and we do find that there's a clonal evolution that is happening, we can always take them at that time to a reduced intensity allogeneic transplant. And there is also some experimental evidence that hypomethylating agents might help.
Great. Another question that comes up about the source of donor and risk of late effects. Specifically, are there any things that you can highlight relative to what we might know about differences in risk in, sibling, matched allogeneic versus mismatched versus haplo mismatched and so forth?
Right. And fantastic question. We have to extend our time that we stopped our cohort at to further down the line in order to answer that question. It was only around 2012, 2014 that the haploidentical transplants or mismatch-related transplants started taking off. And we have a very limited number of patients in that group. So it's an unfortunate thing. But I would love to answer that question by extending our cohort down the road in order to address that question.
Okay, great. And maybe one final, can you discuss a little bit about the COG long-term follow-up guidelines? And specifically, the questioner was interested in terms of the recommendations that are in the guidelines that relate to BMT populations. Are these really, are these the recommendations that you would suggest that these patients be followed by?
Yes, absolutely. The BMT associated guideline recommendations within COG are vetted heavily by people who are experts in BMT outcomes, and all the current recommendations are pretty much in line with what we have found in our studies and others have found.
Great. And then actually, I'm going to end with one question of my own for you. And that is, what do you think what's going to require for us to really understand the contribution of therapy prior to transplant, not the preparative regimen, the prior for the primary cancer versus the preparative regimen versus the treatment following? What's it going to require for us to really understand what the contribution of those different exposures at different time points will actually be?
Right. And that's a fantastic question. So we have, for example, in our cohort, 10,000 patients. And what we have done is mounted a huge effort in terms of gathering all the pre-transplant exposures, as well as the transplant-related exposures, which we gather anyways. And then the post-transplant, what are increasingly being used as consolidation or maintenance treatments, for example, in myeloma patients. We have to anchor our complications with respect to when those exposures occurred, and in order to be able to see what the contributions of those individual discrete pieces of exposures were towards these entities. So, for example, when we looked at cardiovascular events, for example, cardiomyopathy, it was very clear that it was the anthracyclines that contributed to it, and not the TBI, and not the cyclophosphamide, high-intensity cyclophosphamide that was used for conditioning. And then it was the post-transplant cardiovascular risk factors. When we looked at the TBI and breast cancer question, we actually had to exclude patients who'd received chest radiation prior to transplant in order to be able to answer that question. When we looked at therapy-related leukemia and said, does TBI play a role? And what about the alkylators and topoisomerase II inhibitors prior to transplant? We had to catalog them individually. And yes, indeed, we were able to find an independent association with TBI in terms of the risk.
Great. All right, Smita, we want to thank you so much for a terrific lecture. I mean, this was fantastic, and we look forward to more results coming out of the BMT survivor study as the years go on. So thank you again.
Thank you so much for this opportunity. Thank you.
Bye now.
Bye.